In this lecture, we are going to continue with the second part of the lecture series we started on fetal membranes. We had started on fetal membranes, and the first fetal membrane we talked about was the amniotic sac. So today we are going to pick from there, where we are going to now talk about the other fetal membranes. So that's what I'm calling part 2 of the lecture. But just to recap on what we said about fetal membranes, we agreed that fetal membranes are tissue layers that usually cover the baby, hence separating the baby from the inner lining of the uterus, which is the endometrium. Of important to note is that fetal membranes are of zygotic in origin. This is to mean that the genetic makeup of the cells that form the layers, the fetal membranes, the genetic makeup of those cells are similar to the genetic makeup of the baby because they come from product of conception. We agreed that there are 4 components of fetal membranes. We have the amniotic membrane, the Yolk Sac, also called umbilical vesicle, the Allantois, and the chorionic plate, or you can just call it the chorion. So in this image, this is the amniotic membrane, this is the Yolk Sac, this is the Allantois, and this is the chorion. In terms of our objective, we agree that for each fetal membrane, we look at the following. We want to know when this membrane is formed and how that membrane is formed. We also want to know the key role this particular membrane plays during pregnancy. The third thing we want to know is, after that membrane has performed those functions, what is the fate of that membrane? What becomes of it eventually? And lastly, because we are clinicians, we also want to know if there's some abnormalities that are associated with this fetal membrane we'll talk about. And also if there's some diagnostic tests that can be utilized because of this fetal membrane, again, we'll talk about them. And that's what I'm calling clinical aspects. So you'll remember we've already done fetal amniotic membrane. So we're going to do the other 3 membranes. But before we look at the other 3 membranes, I'll remind you again about how the embryo falls, because this is going to become important in our understanding of the next fetal membrane. So just to tell you that the embryo usually falls in 2 planes. There is what we call the folding in the longitudinal axis. We call this the craniocaudal folding. And there is folding in the transverse axis. You can just call the transverse or the lateral folding. The folding of the embryo has multiple morphological effects on the baby. These morphological effects could just affect the overall shape of the baby as a whole, but it can also influence the position of various organs within the baby. So I want to take you through those 2 types of folding. And I want you people to be able to pick out what are the possible overall change in the shape of the body and what are the possible changes in various organ positions as the embryo folds. So the first video I'm going to show you is showing you embryonic folding in the transverse axis, what we call lateral folding. So with that being the ectoderm, mesoderm, endoderm, the green being the notochord. So this is the trilaminar embryo. First of all, what we are seeing at the moment is folding of the ectoderm in the process of neurulation. That is not part of the transverse folding. We also appreciate that the mesoderm is divided into 3 parts: paraxial, intermediate, and lateral plate mesoderm. But now we are seeing the transverse folding itself. As the embryo is folding transversely, we've seen that the dorsal part of the embryo has been incorporated into the baby. That's what we call the primordial gut. The yolk sac has become smaller. The amniotic sac has expanded. The shape of the baby has become cylindrical. In the sagittal axis, want to see now folding in the sagittal axis, what we call craniocaudal folding. So again, this is the baby, this is the trilaminar embryo with ectoderm, mesoderm, endoderm. This is actually from the site where the heart is going to develop. And we had to believe that for now, but we are going to see that that's actually true. This is the developing brain. That's the Allantois. So amniotic sac, yolk sac. See how the embryo is now folding in the craniocaudal axis. With this folding, the heart descends to the thorax, the brain becomes cranial, the yolk sac becomes smaller, as you can see. The amniotic sac is expanding. The connecting stalk is being formed here. Look at how the dorsal part of the yolk sac has been incorporated into the baby. The ventral part of the yolk sac remains outside. The overall shape of the baby, we now see the fetal curvature that we know. So to just build on what I've told you, I want you to take this as your assignment. At your own time, look at this. What are the effects of embryonic folding in the transverse plane? So just highlight the outcome of embryonic folding in the transverse plane, the results of embryonic folding in the transverse plane. Also look at the results of embryonic folding in the craniocaudal axis. So that you'll do at your own time, just to build on that story. Okay, now let's talk about the second fetal membrane. We call the second fetal membrane the yolk sac. Some authorities will prefer calling it the umbilical vesicle. Just like the amniotic membrane, the yolk sac is also formed during the second week of embryonic development. In terms of the mechanism of its formation, unlike the amniotic membrane where the cells of the epiblast were the ones that migrated away from it, in this case, the cells of the hypoblast are the ones which migrate away from it. So this is hypoblast. These are the cells of the hypoblast migrating away from it to constitute the yolk sac. Well, when this reaches the third week, remember we mentioned that the hypoblast become replaced by endoderm. So it means later on then that the yolk sac will then be lined by endoderm and not hypoblast, because endoderm replaces hypoblast during gastrulation. So that's how yolk sac is formed. What are the key functions of the yolk sac? Yolk sac is important for transfer of nutrients before the placenta is established. It is also important as being one of the sites where blood formation occurs. The process of formation of blood is called hemopoiesis. You may not know this, but there's a time that blood has to be formed in the yolk sac and perhaps in the allantois and in the chorion. Then later on, once the liver of the baby has formed, the blood cells will now be formed in the liver and perhaps in the spleen and some lymph nodes. Then later, once bone has been formed and there's bone marrow, blood is now formed within the bone marrow. So there are those stages of hemopoiesis before birth. So earlier on, it is the yolk sac, the first site. Last but not least, in our lectures of gametogenesis, we indicated that the yolk sac gives rise to the primordial germ cells. So this is where the primordial germ cells came from. The cells come from the wall of the yolk sac. Then they migrate and invade the developing gonad to give rise to spermatogonia or oogonia, depending on the type of gonad we're talking about. So these are the key functions of the yolk sac. What is the fate of the yolk sac? We have already partly alluded to the fate of the yolk sac. The dorsal part of the yolk sac becomes incorporated into the embryo when the embryo is folding. And that dorsal part of the yolk sac, which becomes incorporated into the embryo when the embryo is folding, will therefore become the primordial gut. This is the primitive alimentary canal. The ventral part, however, degenerates. Just means it involutes, it disappears. So in its journey of disappearance, there'll be first a narrow connection between the primordial gut and the yolk sac that is involuting. That narrow connection is what we call the vitelline duct. This vitelline duct also disappears eventually. So in these images, we see that aspect being depicted. The one above is the amniotic cavity, the one below is the yolk sac. We see in this image the craniocaudal embryonic folding being demonstrated. And through this, we see that the dorsal part of the yolk sac is slowly and progressively being incorporated into the baby to constitute the alimentary canal. But at the same time, we see that the yolk sac, the ventral part of it, is actually remaining outside the baby. This is the yolk sac that will disappear. Yet again, we appreciate that there's a connection between the yolk sac outside and the primordial gut. So that connection is what we call the vitelline duct. I've indicated to you that this vitelline duct should disappear. The persistence of the vitelline duct, failure of disappearance of the vitelline duct, therefore, would lead to a spectrum of malformations that we call vitelline duct malformations. And that brings me to, therefore, the clinical relevance of the yolk sac. So the disorders associated with the yolk sac are disorders associated with persistence of the vitelline duct. So in the first image, it shows us a vitelline duct that persisted and still attached to the intestine. This is what we call Merkel's diverticulum. So this is the small intestine, and this is the diverticulum. Merkel's diverticulum usually is not a good thing to have, because in as much as we're wondering what's the big deal, is not passing food anyway, there could be some issues. One is that the neck here could be blocked. And so this region here become a blind tube, which then can proliferate a lot of bacteria. So it can actually burst, swell and burst. But we're also worried about the type of cells that are usually within Merkel's diverticulum. The type of cells that are usually within Merkel's diverticulum are similar to the type of cells which are in the stomach, the ones that produce acid. So Merkel's diverticulum also produces acid, just like the stomach cells. That becomes a bit scary because this one does not have the mechanisms that prevent against the acidity. So it can easily perforate because of the acidity. The second image shows us a persistent vitelline duct, which is still continuous with the anterior abdominal wall, and there's a patent lumen. Because there's a patent lumen, we then call it vitelline duct fistula. The third one shows vitelline duct, which has involuted on the abdominal side as well as on the intestinal side, but in the middle, it did not involute, so it remained as a cyst. Therefore, we call it vitelline duct cyst. The last one shows us two things. First, it shows us persistence of the duct on the abdominal side. So it's like a tract with a blind end. So a tract with a blind end from the anterior abdominal wall side, from the umbilical side, is called umbilical sinus. But this umbilical sinus is due to persistence of the vitelline duct, so we call it vitelline duct sinus. You may have other types of umbilical sinuses, which are not necessarily from persistence of the vitelline duct, and that's why it is important to specify that this one in particular is vitelline duct sinus. The other thing this is showing us is this region between the intestine and the anterior abdominal wall, where there's a fibrous material that has persisted in place of the vitelline duct that was supposed to have involuted. This is called fibrous cord. So those 5 are the spectra of malformations which are due to persistence of the vitelline duct. We call them vitelline duct malformations. Now we can make a summary of what we've said about the yolk sac. We have indicated that the yolk sac forms during the 2nd week of embryonic development, and this is formed by the cells of the hypoblast migrating away from the hypoblast. We have also indicated that in terms of functions, the yolk sac is important for transfer of nutrients. It's also important as a site of formation of blood, and it gives rise to the primordial germ cells. In terms of fate, we've mentioned that the ventral part involutes initially as vitelline duct, which then is supposed to disappear completely. The dorsal part become incorporated to form the alimentary canal that you and I have. In terms of in terms of clinical relevance, we've given a spectrum of malformations which are likely due to persistence of the vitelline duct, and so we call them vitelline duct malformations. So we've mentioned vitelline duct fistula, vitelline duct sinus, fibrous cord, Merkel's diverticulum, and vitelline duct cyst. We can now pick the 3rd fetal membrane. The 3rd fetal membrane we want to talk about is the allantois. In terms of formation, allantois is just an extension of the yolk sac into the connecting stalk. It's an extension of the yolk sac into the future connecting stalk. Therefore, in terms of functions, the allantois shares the same functions as those of the yolk sac, which means it will give rise to the primordial germ cells. It is also important for transfer of nutrients and the site of formation of blood cells. However, apart from those 3, the allantois also contribute to the formation of the blood vessels which connect the baby and the placenta. We name those as umbilical vessels. Initially, we have 2 umbilical veins and 2 umbilical arteries, but one of the umbilical veins disappear, so that eventually we have 2 umbilical arteries and 1 large umbilical vein, all contained within the umbilical cord. And you remember, this was surrounded by some embryonic connective tissue, which we call Wharton's jelly. So in terms of fate, what happens to the allantois? The first image shows us the allantois, as well as the primordial gut. The region where the allantois and the primordial gut are still connected is this caudal region, which we call the cloaca. The cloaca represents the primitive connection between the urogenital tract and the gastrointestinal tract. So the urogenital tract is represented by the allantois. The gastrointestinal tract is represented by the Yolk Sac or the primordial gut. So that cloaca is the primitive connection between the two systems. In mammals, and you and I are one of them, the cloaca become partitioned. I mean, it becomes split so that the urogenital tract is completely separated from the gastrointestinal tract. So that will happen much later, and we'll talk about that. Once that separation has occurred, the anterior part of the cloaca is still continuous with the allantois. The lower end of that allantois become incorporated into the urinary bladder. So it forms part of the urinary bladder. And that's a fact I want you to remember, that the lower part of the allantois is incorporated into the urinary bladder. The upper part of the allantois, which is this part here, has a different fate. It usually collapses. And that collapsed allantois is what we call the urecus. As time goes by, the urecus is expected to just solidify. It is expected to lose its lumen and just become a solid material. And that solid material is what we call the median umbilical ligament. So the median umbilical ligament is a remnant of the urecus. It's a remnant of the urecus, and you and I have the median umbilical ligament. So therefore, that brings me to now the implications of the urecus not having disappeared. But let's see here. So this one is the median umbilical ligament, which is basically a remnant of the allantois. Now let's talk about the clinical importance of the allantois. This is likely based on the persistence of the allantois. Now, we have said that the allantois is supposed to basically form the urinary bladder on the lower part, and on the upper part is supposed to involute first as urecus, then becoming a median umbilical ligament, which connects the urinary bladder to the umbilicus. So the question is, if the urecus persists, which means we don't form the median umbilical ligament, what happens? We will get a spectrum of malformations that we call urechal malformations. So let's go through this spectrum of urechal malformations. Let's consider this first image as part of the allantois that has involuted. So this is the anterior abdominal wall, and this is the perineum. The perineum is the lower part of the body. This bag is the urinary bladder. So this is urethra. So let's assume that from here to there was supposed to be what is becoming the allantois, or rather what allantois was. So the lower part of the allantois has been incorporated into the urinary bladder. The upper part of the allantois has collapsed. So at this point, we have the urecus. The normal fate is that the urecus then collapses, or rather solidifies, to become a ligament. And that ligament is what we call the median umbilical ligament. So this is the normal state of it. Now let's the second image. So in this second image, I'm showing you a similar thing, but the whole of the urachus has not solidified, which means it has a lumen that is connecting the urinary bladder to the anterior abdominal wall. You will have a communication. The term given to abnormal communication between two epithelial surfaces is a fistula. So we call this malformation urachal fistula. A newborn with urachal fistula will be expected to be passing urine, leaking urine through the anterior abdominal wall, because urine comes here, then passes through that end to the anterior abdominal wall. In the third image, we see urachus, which has become the ligament only on the lower part of it. The upper part of the urachus has not become a ligament. So what do we have? We have a tract from the umbilicus with a blind end. It is one of the forms of umbilical sinus. But because this is related to Allantois, we call it urachal sinus. It's called urachal sinus. A sinus is a tract with a blind end. A fistula is a tract with both ends open. So this one has only one open end, the other one is blind, so we call it a sinus. So this is urachal sinus. It is an example of umbilical sinus. In the fourth image, we see urachus that has involuted to become a ligament on the proximal and the distal ends, but somewhere in the middle, that has not happened. So this is a cavity that has no opening, and that's what we call a cyst. So we call this urachal cyst. And lastly, in this last image, we see urachus that has become a ligament on the upper part. The lower part has not become a ligament. So this lower part is continuous to the urinary bladder. It will then appear like an extension of the urinary bladder, so we call it bladder diverticulum. So these are the spectra of malformations that we call urachal malformations. So we're done with the Allantois. In terms of formation, it's an extension of the Yolk Sac into the connecting stalk. In terms of functions, so the functions of Yolk Sac are also here: transfer of nutrients, hemopoiesis, give rise to primordial germ cells. And then unique to Allantois is that it contributes to formation of the umbilical vessels. In terms of fate, the cranial end will involute initially as urachus, then become the median umbilical ligament. The lower end is incorporated into the urinary bladder. The clinical aspects of the Allantois are related to persistence of the urachus, so giving rise to a spectrum of malformations that we are calling urachal malformations: urachal fistula, urachal cyst, urachal sinus, and bladder diverticulum. Let's now talk about the last fetal membrane. I want to give you a minute or less to just remind yourself of these structures here, the ones labeled. Just remind yourself, so what's A, what is B, what is C, all the way to the last one in 30 seconds. Okay, so I believe you've already reminded yourself of those structures, and I hope that you said A, yeah, the trophoblastic lacunae. I hope you said B is a connecting stalk. C is the amniotic sac or the amniotic cavity. We have the yolk sac there, labeled D. I am more interested in this one. Structure E is the somatic layer of the extraembryonic mesoderm. Then structure F is the cytotrophoblast. G is the chorionic cavity. And I'm also interested in H, which we call the syncytiotrophoblast. In terms of timing, we can see two layers here. So the second week, and we can see that implantation is complete because structure I is the decidua or the endometrial lining. So in terms of timing, the end of the second week of development. Now, the fourth fetal membrane is the chorionic plate. What are the components of the chorionic plate? The components of the chorionic plate are the following. We have the somatic layer of the extraembryonic mesoderm. We have the cytotrophoblast, and we have the syncytiotrophoblast. These are the components of the chorionic plate. The chorion is described to have two parts. I want you to follow the cytotrophoblast keenly and notice that this lower end doesn't have some things that look like spikes, but this upper end has those things which look like spikes. Those spikes are known as villi. Based on that, we can say that the chorion has two parts. There's a part of the chorion that has prominent villi. We call it villus chorion. The other name given to the villus chorion is chorion frondosum. The term frondosum means bushy or villus. So this is the bushy or the villus chorion. And the other part of the chorion is the chorion which is not villus. You can call it the non-villus chorion. The non-villus chorion is also known as the chorion leaf, written that way. Chorion leaf, the term leaves means smooth. So this is the smooth chorion or chorion leaf. Fine, so I've told you the layers of the chorion. It's made up of 3 layers. I've also taught you the parts of the chorion frondosum and chorion leaf. What are the functions of the chorion? The chorion frondosum forms the fetal component of the placenta. I consider that as a function as well as a fate, basically. The chorion frondosum contribute to the formation of the placenta. Apart from contributing to formation of the placenta, the chorion protects the embryo. It's a very big structure surrounding the embryo, so it protects the baby, basically. And lastly, the chorion, just like yolk sac, also participate in formation of the blood cells. I'd alluded to you earlier on the fact that there are different phases of blood formation. And I told you that the first phase of blood formation is where blood is being formed within the yolk sac. So the yolk sac phase of hemopoiesis is that period when blood is being formed in the yolk sac, in the allantois, and within the chorion, that the yolk sac phase. Then the second phase is what we call the hepatosplenic phase, when blood is being formed in the liver in the spleen as well as in the lymph nodes. The last phase which a child is born with and also persists postnatally is the intramedullary phase, where now blood is being formed within the bone marrow. So I've told you the functions of the chorion. How do we clinically utilize the chorion? The clinical utility of the chorion is, on one end, on the possibility of us making a diagnosis of early pregnancy. For us to make a diagnosis of early pregnancy, we rely on two things, and all of them are actually chorion-based. One of them is that we can detect the levels of beta HCG, either from urine or from blood samples. So high levels of beta HCG suggest that there's a pregnancy. And so these are laboratory tests. Remember, beta HCG is produced by the chorion. You know, HCG stands for human chorionic gonadotropin. So this is chorionic, which means it's coming from the chorion, specifically produced by the syncytial trophoblast of the chorion. But also, we can just visualize the chorionic cavity using ultrasound. Visualization of the chorionic cavity using ultrasound is also a diagnostic marker of early pregnancy. So again, you realize we're relying on the chorion. The chorionic cavity is what is called gestational sac. So in this image, we see this is the gestational sac. This is the chorionic plate, basically. And this is what we call the fetal pole, which means the baby. It can even tell us, like when they are twins, we can even tell which type of twins they are. Like in this case, we can see we have dichorionic, diamniotic twins. This is one gestational sac, that's another gestational sac. Each of them have their own amniotic sac. As you can see, there's a thin membrane there, the amniotic membrane. So basically, each baby here has their own amniotic sac as well as the chorionic cavity. Apart from diagnosis of early pregnancy, we can also utilize chorion through what we call chorionic villus sampling. Chorionic villus sampling can be done for similar indications like that for amniocentesis. We talked about amniocentesis in the previous lecture. We agreed that it's an ultrasound-guided procedure of obtaining amniotic fluid. Now, for chorionic villus sampling, it is still ultrasound-guided procedure for obtaining tissue sample from the chorion. What we do with this tissue sample is similar to what you could have done with the amniotic fluid sample. You can do some genetic studies for paternity or for malformations or whatever. We can also test other things. Now, there is an advantage that chorionic villus sampling has over amniocentesis. And that advantage is that chorionic villus sampling can be done earlier. You know, you can't do amniocentesis early because, first of all, you have to wait for the adequate volume of amniotic fluid that you can aspirate with a syringe. But chorionic villus sampling can be done much earlier. That's the advantage. There is, however, also a disadvantage of chorionic villus sampling over amniocentesis. And I hope you've realized I'm just comparing the two. So the disadvantage of chorionic villus sampling is that it's a high-risk procedure. This procedure can lead to bleeding at the chorion and sometimes even complicated a lot of bleeding and termination of the pregnancy. So that's the disadvantage, which makes then amniocentesis safer when compared with chorionic villus sampling. So we are done with the fourth fetal membrane, that is the chorionic plate. We've talked about how it's formed, and we've agreed that it's formed by the three layers: cytotrophoblast, syncytiotrophoblast, and the somatic layer of the extraembryonic mesoderm. In terms of function, we've said it protects the baby. I forgot to tell you that's also for transfer of nutrients. Let's take that up. And that it was also a site of formation of blood cells. In terms of fate, usually the villus chorion, the chorion frondosum, contribute to formation of the placenta. And so I consider that as a function as well as a fate. In terms of clinical aspects, we utilize the chorion in early pregnancy diagnosis, either through laboratory methods where we check the levels of beta-HCG, which is produced by the chorion, but also by visualizing the chorionic cavity, which is also called the gestational sac, by ultrasound. Apart from early pregnancy diagnosis, we've also talked about chorionic villus sampling, which is a method of diagnosing. It's a procedure that can be done. So we are done with fetal membranes. However, this talk is never complete. The talk of the chorion is never complete unless we talk about the placenta. We will not talk about placenta in details, but I'll highlight a few aspects that I want you to know about the placenta for the sake of this lecture. So I don't consider placenta as a fetal membrane based on how we defined fetal membranes. That fetal membranes are tissue layers of zygotic origin. The placenta is not entirely of zygotic origin. The placenta is a fetal-maternal organ. And that hard term simply means that the placenta has a fetal component and a maternal component. The fetal component of the placenta is what we have called the chorion frondosum, the villus chorion, the chorion with villi, and that is the chorion frondosum. The maternal component of the placenta is known as decidua basalis. In our earlier talk, I told you that decidua is basically the endometrium during pregnancy. So there are different terms given to the decidua. The decidua at the site of implantation is known as decidua basalis. And that's the one that contributes to formation of the placenta. The decidua that is away from the site of plantation has different names depending on where it is. So like the one that's covering the rest of the endometrium away from the site of implantation is called decidua parietalis. Then the one that is covering the pregnancy itself at the site of implantation is known as decidua capsularis. So parietalis and capsularis do not contribute to formation of the placenta. The one that contributes to formation of the placenta is the decidua basalis. That's why we are saying that the placenta is a fetal maternal organ. So what are the functions of the placenta? The placenta has exchange functions. So a number of substances are exchanged at the placental site. For example, oxygen moves from the mother to the fetus through the placenta. Carbon dioxide moves from the fetus to the mother through the placenta. Nutrients move from the mother to the fetus. Antibodies move from the mother to the fetus. And the antibody we're talking about here is called antibody G, immunoglobulin G. We know that water also moves and that water has a bidirectional course of movement. It can move from the fetus to the mother or from the mother to the fetus. That is part of what we call the transmembrane pathways of fluid movement. Apart from exchange of substances, the placenta also produces some hormones. Human chorionic gonadotropin is a very important hormone, as we talked about previously. It is the one that enables persistence of the corpus luteum, so that corpus luteum can continue to produce progesterone that sustains the pregnancy. Estrogen is important during pregnancy because it enables enlargement of the uterus as well as breast development. Progesterone is important during pregnancy because it also maintains a pregnancy. So usually, initially before the placenta is formed, the progesterone hormone will be coming from the ovary. And that's why we need this hormone to ensure persistence of the corpus luteum so that the ovary can continue to produce progesterone until the placenta takes over. Once the placenta takes over, it means that it will be producing its own progesterone to maintain the pregnancy. Apart from maintaining pregnancy, progesterone is also important for development of the breast, just like estrogen. And lastly, we have HPL, which stands for human placental lactogen. Human placental lactogen promotes breast development during pregnancy. The third function of placenta is metabolic functions. And what I just want to say here is that placenta metabolizes glycogen. This is the key nutrient that is usually used during early development, glycogen. So having told you the components of the placenta and the functions of the placenta, I want to talk about some abnormalities of the placenta. Structural abnormalities. We'll not talk about functional abnormalities, we'll talk about structural abnormalities of the placenta because we are talking about anatomy here. I hope somebody's not wondering, so what's the usual fate of the placenta? I hope nobody's wondering about that. But I also hope you know that the usual fate is that when the baby is born, the placenta also comes out after the baby's been born. So basically, that's the normal fate. Okay, let's talk about structural abnormalities of the placenta. In the first image, we see a placenta that is lower down in the birth canal. In our previous talk, we call this placenta previa. And he said the placenta previa is a low-lying placenta. The problem with a low-lying placenta is that it obscures the birth canal. And this type of low-lying placenta, which we call grade 4 placenta previa, there's no way this baby can come out unless the placenta comes out first. And that will be catastrophic because the moment the placenta separates, it means that it cuts off oxygen supply. So if the baby is not yet born, then that baby will not have oxygen. Usually, the placenta should separate once the baby has been born. But in this one, it will have to separate before the baby is born. So if this baby, someone proceeds to deliver this baby vaginally, there are higher chances that this baby will be a stillbirth when this baby comes out through the vagina. Placenta previa is a low-lying placenta. Then we have this type of placenta where the umbilical cord is not attached to the center of the placenta, but is attached to the edge of the placenta. We call it battledore placenta. Yet another one In this third image, we see a placenta with two lobes. So we see this lobe here, and we see that other lobe here. They are both served by this umbilical cord. We call this the bilobed placenta. You may call it bipartite placenta to mean placenta with two parts. Here we see a placenta that has everted edges. The edges of the placenta here are everted. Yes, the umbilical cord is attached at the center, but the edges are everted. We call this circumvallate placenta. You can call it placenta circumvallata. In the second image, we see umbilical cord has come and it has branched. So the branches, the umbilical vessels have branched before the umbilical cord can reach the placenta, which means that the umbilical cord is attaching at the membranes and not on the placenta itself. We call this placenta velamentosa or velamentous placenta. In the third and last image, we see a placenta that has a bigger part there being served by that umbilical cord, and a smaller part of the placenta which is separate from the main one. This is called accessory lobe of the placenta. Accessory lobe of the placenta is also known as placenta saccenturiata. Don't confuse placenta saccenturiata with bipartite placenta. Then there are those malformations of the placenta which were due to excess penetration or invasion of the placenta into the uterine wall. We talked about them, but we can recap. Let's consider this to be the layers of the uterine wall: endometrium, myometrium, and perimetrium. And that endometrium has two zones, the stratum functionalis and stratum basalis. When implantation takes place, the attachment is up to that point, the junction between stratum functionalis and stratum basalis. So this part here contribute to formation. This is the part we are calling the decidua basalis, which contribute to the formation of the placenta. That would be normal. You may, however, have a situation where the chorion frondosum has penetrated deeper up to the myometrium. So basically beyond the decidua. This is what we call placenta accreta. Yet again, a more severe form is where the chorion frondosum has penetrated deeper into the myometrium. This is what we are calling placenta increta. And the last form of it is where the chorion frondosum has penetrated all the layers of the uterine wall. This is what we called placenta pacreta. In terms of severity, the pacreta is more severe compared to the accreta in terms of incidence. So this is, in most cases, 75% of them will be accreta, 17% of them or 18% of them will be increta, and perhaps 7% of them will be pacreta. Just looking at the abnormal ones. The problem with this type of placentation is that once this baby has been born, the placenta will refuse to come out. So you'll have what we call retained placenta. And this can be associated a lot of bleeding after delivery, what we call postpartum hemorrhage. Right, so that's it for what I wanted you to know about the placenta. And so we will stop there. Our next topic will be on the fetal period of development, where we'll be looking at what happens during the fetal period of development. So we'll stop there for today. Thank you very much.